patient, we have some subtle increased intensity in the cortex and in the thalamus. It's in contrast to acute infarct. However, when we do SWI, we see the hypoxygenation may be a surrogate for perfusion imaging without using any contrast material. And 4 days later, after migraine attack, the hypoxygenation will reverse back. I was talking about these unnecessary things to follow up, but they are really being followed very, very frequently, and the children receive gadolinium unnecessarily. For example, the arachnoid cyst, choroid plexus cyst, pineal cyst, or choroid fistula cyst. So they are really unnecessary. Talking about the inherited metabolic diseases, so some of these patients come with a special pattern that we can put the diagnosis straightforward. However, in the unknown cases, we should give gadolinium because, for example, in Krabbe disease or paroxysmal disease or the Alexander's disease, the gadolinium enhancement may give some clues about the diagnosis. And in adrenoleukodystrophy, prior to bone marrow transplantation, we want to calculate the lowest score, which would indicate the prognosis. And so gadolinium application is necessary in these children. So just talking a few words on unenhanced MR angiography of the brain, which is a routine application in children, actually in adults as well, because there's no radiation exposure or contrast material and easy to follow. We are used to it and very easy to interpret. Yes, it suffers from something, for example, long acquisition times or limited imaging range or pseudostenosis in vessels parallel to the imaging plane or intravoxal dephasing. But some technical modifications can be done accordingly. For example, in this patient with stroke, there is a cortical and subcortical chronic infarct here, increased vessel intensity in the sylvian fissure, and we see decreased vascularity on TOF MRA. And for example, a time-of-flight MRA is necessary and enough to follow up this patient. We can easily tell that there is a vasculopathy, focal vasculopathy in that area. However, in such cases like vascular malformations, if we want to see the dynamic pattern, the enhancement, feeding pattern of these lesions, so then we should inject gadolinium and see dynamically the enhancement pattern of the lesions. Please compare that we can easily locate the nidus of the lesion on time-of-flight MRA, but we can see that it is fed by external carotid artery on dynamic enhanced MRA. However, again, for example, in patients with Moyamoya syndrome, we can do time-of-flight MRA and we can easily follow up these patients. In this patient, we see some subcortical lesions here, and on brain MRA, we see steno-occlusion in the right MCA and very crowded deep collaterals here. So it's enough for us to follow up these patients, so no necessary. However, if these patients are considered for a surgery, then we have to state the presence of the collateral vascularity and the perfusion status of the parenchyma. So we give contrast, and then if we see increased cerebral blood volume in that area, we can say that still the cerebrovascular reserve is preserved in this patient. Just a few words on arteriospin labeling, which is very popular nowadays. It's usually done at 3 Tesla imaging, but there are some papers coming out stating that it's okay with 1.5 Tesla, and both techniques could be used. And the papers tell that there's a good correlation between CBF derived from ASL and CBF and CBV derived from dynamic susceptibility imaging. So it can be used in stroke, of course. However, it can also be used for imaging of the tumors, even discriminating between high-grade and low-grade tumors in pediatric brain imaging studies. So even there are some authors doing some perfusion reserve assessment with acetoazolamide or dynamic MR angiography. This is a very recent paper comparing ASL and dynamic susceptibility contrast imaging on pediatric brain tumors. We can see, and performed at 1.5 Tesla, we can see that there is a good correlation between the two perfusion methods using contrast and non-contrast techniques. Here a case from a colleague. So we see here a tumor with an enhancing portion, however showing hypoperfusion on both imaging types. So this case proved to be AA or grade 1. I want to conclude with this poor boy who had annually pituitary imaging just for this pars intermedia cyst here, and received already 3 doses of gadolinium here at this young child. So to conclude up, I think still use of gadolinium-based contrast agents in neuroimaging is inevitable, and we get a lot from that. But its use can be considerably reduced in children. And the clinical reasoning is important for both MRA and gadolinium use. The most efficient way, I think, to reduce the use of these agents is to check the examinations while the patient is being scanned. I know it's hard in busy departments, but I think the best way is that. And we should always try non-contrast studies first, especially on assessment of the vascular status of the tissue, and use TOF MR angiography